All right, so they are ending the other session now. I will give it about another 2 minutes and then you can go ahead and get it started, Mr. Weston.
All right, great, thanks. So I'll start at 3:31 here.
Got it.
Okay, thank you all for joining us for today's webinar. The title for this session is Substance Use Disorder and Social Stigma, Research and Dissemination Efforts at Penn State University. My name is Dr. Weston Kensinger. I'm the director of the Douglas W. Pollock Center for Addiction Outreach and Research at Penn State Harrisburg, and I will be your moderator for today. Today we have 5 different groups presenting from Penn State, so we're going to keep things moving. The first one to present is going to be Dr. Irvga Kainak. She's going to be presenting on associative and vicarious stigma, how addiction impacts the family unit. And just to note to the participants, we will leave time at the end for questions, but we want to make sure that all our presenters can share. So Irvga, I'm going to stop my screen and you can go ahead.
Hey, thanks, Weston. Can everyone see that? All right, so as Weston said, I'm going to be talking about associative and vicarious stigma. I'm going to get right into things because we don't have a lot of time. So family members of individuals with chronic and life-threatening illnesses frequently rely on compassion and support from individuals inside and outside of the family, unless that disease is substance use disorder. Why is that? Well, we believe that stigma can shed some light here. So stigma can impact, we know it can impact people with substance use disorder across the spectrum of the disorder, from diagnosis to recovery. But what's less understood or less studied is how this stigma can spill over to the family and how that can impact their well-being, as well as their willingness to support loved ones with substance use disorder. So there are 2 types of stigma we're going to look at today that perhaps you aren't aware of, and that's associative and vicarious stigma. Associative stigma, or stigma by association, is when stigma spreads from the stigmatized individual to their close connections. Vicarious stigma, or stigma by proxy, is when stigma is experienced indirectly by family members. And both types of stigma here are associated with negative health outcomes, including depression, anxiety, and maladaptive coping skills like secrecy. So with the data I'm about to present, I hope to answer a number of questions related to family members' SU and stigma. First, how do family members believe that SU stigma has impacted their loved ones? Also, who is doing the stigmatizing? How do family members believe that SUD has impacted them personally? And how can we help support family members? The data I'm presenting today came from the opioid stigma reduction campaign, Like Unites Us, which is funded by the Department of Drug and Alcohol Programs. There are various components to the study, which perhaps some of you are familiar with since we presented last year on the campaign. But the main objective of Like Unites Us is to reduce SUD stigma through a social media campaign. And two of my colleagues are going to be reporting some of the other data that we have from the study, but the data that I'm presenting today came from one-on-one in-depth interviews that were conducted every 6 months. I'm looking specifically at the 40 interviews that were done with family members of individuals with SUD. And I'm really not going to spend any more time than that on the methods because I'd like to get straight to the results. But if you have questions, we can chat after the panel or you can contact me. So let's start by identifying who family members reported was doing the stigmatizing. So as you can see, sources of stigma were pervasive. Family members reported stigma from almost every group that they came into contact with on any given day. So in community, healthcare settings, and the justice system. And these different groups are going to come out as we go through the data. So what are some of the messages that parents or that family members were receiving? So first up, how does stigma present to family members? And themes that emerged in this qualitative data included associative and vicarious stigma. So just a heads up of how I'm going to present this data. I'm going to present the qualitative results by first letting you know the overall theme, then reading one family member quote, and then finally summarizing overall findings related to that theme. We do have multiple quotes per theme, but due to time, I can. So first up, stigma impacts families by proxy, so vicariously in a variety of settings. First up, family, peers, and school. So read the quote. So this principal just kept saying to her, "You used to be such a great kid. Now look at you. You've made this mess of your life." And I was just like, "That's it. We're done. You can't talk to her like that. I have to deal with this, but you can't make her feel like garbage." So family members recounted the pain and anger they felt when their loved one encountered judgment, shame, and disrespect because of their substance use disorder. And for parents, especially watching their children internalize this message of being a bad person was extremely distressing for them. So community at large, we wanted to plant a tree or put a memorial park bench out in the community. And we were told politely that this type of thing was reserved for people who were more revered in the community, not for people who died by their Sunday. So family members are told by the community that their loved ones are undeserving of sympathy and support, and the community dismisses the value of human life when that human life has a substance use disorder. And then treatment settings, and this is a long quote, but I'll just go to the underlined part, which is a doctor talking to this family. "Do you realize you're an addict? These two people in the room are probably the only people in the planet who care about you. When are you going to wake up and get over it?" This is how a doctor talked to our son. So family members observed loved ones being treated poorly by those who were supposed to help them. And then stigma impacts families by association, so associative stigma. There's definitely a label on everybody from this family. Anybody that probably knows us intimately. I think I'd be naive to say there wasn't. So family members felt that they were negatively labeled due to their loved ones. Next up, how does stigma impact family members? Themes that emerged: shame, isolation, and lack of support. So stigma impacts families through shame. I remember the judge saying to me in front of a court full of people, "You're the problem, you're the enabler." The family members are blamed for their loved one's addiction, and they're shamed when they want to help their loved ones. Social isolation. Everyone has walked out of our life. The neighbors don't talk to us. We've lost all our friends. They've all left. It's very, very painful. Stigma surrounding their loved ones STD left family members feeling alone, and family members found it difficult to navigate relationships where they didn't feel understood or supported. So many were really trauma. So stigma impacts families do not seeking help. You're embarrassed to say it's your kid that's an addict. The stigma that you've done something wrong is there. Some family members reported not seeking formal help because they didn't want to share publicly that their loved one was struggling with addiction, since we're talking about when we talk about secrecy coping, that came up a lot. And then lack of resources. If we had more people willing to say, yes, we need support too, then we would be able to have more support groups. So when family members did take the step to seek out formal help, they reported problems finding services in their area, and stigma was connected to the lack of resources. A lot of our respondents looked online first, came up with few options, and often ended up relying on informal supports instead. And then finally, what do family members want from the community? Things that emerged: empathy, social support, and resources. Family members want understanding and acceptance from society. I wish society understood and recognized that we didn't cause our child or loved one. We didn't drive them to drink. We didn't drive them to use drugs. We didn't cause it. Family members don't want to be ostracized by their community or blamed for their loved one's deed. They also want more resources. There's just not a ton of stuff for families. You find out they have a substance use problem. You don't understand why. Those programs are so important to make you understand. There's so much more to it than seen on the surface. I think every town should have some sort of resource for families. So family members crave knowledge and education, but they had trouble finding them, or they really weren't sure where to start with things. And what did we learn about those who did find support? When they did, they felt that their struggles were valid. So it gave me validation from feelings, anger, the disappointment, the guilt, to hear from other people that what I was feeling was not happening. So when they did seek out support, it was helpful, and they got that support and validation, usually from mutual support. So stigma was prevalent in this sample. Associative and courtesy, vicarious stigma were prevalent. Shame, isolation, not seeking help, a lack of resources were connected to stigma, and family members crave connection and support but had trouble accessing these programs. So we did find that family members asked for trainings, and currently at Penn State we are testing a couple of stigma trainings for health professionals, one for MDs, DOs, MPs, and med students, and another shorter one for nurses, social workers, counselors. We also are developing an echo stigma training for community members. So we're going to be developing and piloting that in the next year, and that one's going to be open to friends and allies. And we really want to help people that get better at understanding how to talk to others about stigma and how to support people, individuals with STD. And then part of the Policy Center is a student lab. And, as right now we have some students working on various studies, one of which is collecting information about programs in our county and beyond, in terms of setting up information that has updated information which is available for members. Okay, thank you very much. And we'll stop sharing. So the next presenter is.
All right, great. Thank you, Dr. Kynack. It's very important to always remember that family members are also impacted by stigma as well. Our next presentation is by Dr. Nathan Kruis. Dr. Kruis is an assistant professor of criminal justice at Penn State Altoona, and he will be discussing NIMBY syndrome, the impact of social stigma. Dr. Kruis, take it away.
Thank you, Weston. Just give me a second here to find my PowerPoint. There it is. All right, so I'm assuming everyone can see that. Please let me know if you can't. Good afternoon, everyone. As Weston said, I'm Nathan Kruis. I'm an assistant professor of criminal justice at Penn State Altoona. Today, I'm going to be sharing with you findings from a project that I've been working on with my colleagues at the Pollock Center that looked at the relationship between one's addiction frameworks or their beliefs about addiction, whether or not they support what we call the moral or medical model of addiction, social stigma of OUD, and support for NIMBY syndrome, for opioid treatment facilities, and punitive attitudes or punitive responses to opioid use. Now, given our time limitations, I'm going to be as brief as I can be today by focusing only on the key parts of our methodology, our findings, and the implications from these findings. As you all know, we are in the middle of a significant decades-long opioid epidemic that has had a tremendous impact on our public health and criminal justice systems. And where I live and work in Pennsylvania, this state has been hit particularly hard by this opioid epidemic, as characterized by some of the highest overdose death rates in the country over the last decade. Now, fortunately, here in Pennsylvania and across the country, we have seen the enactment of many evidence-based responses to this epidemic, such as having law enforcement officers and other first responders carry and administer naloxone, the adoption and implementation of law enforcement deflection or diversionary programs, and the use of medications for opioid use disorders such as methadone, buprenorphine, and naltrexone. And these are all empirically supported responses to this epidemic. Now, unfortunately, the adoption and implementation of these responses has not been ubiquitous. When we look at naloxone, currently only about 20% or 1 in 5 law enforcement agencies across the country actually has a policy requiring officers to carry and administer naloxone. Only about 5% of these departments have a deflection or diversionary program, and the use of MOUD for opioid use treatment throughout the country it's really been underutilized in the criminal justice system and among treatment providers in the public too. We believe, and our preliminary research supports this, that public stigma and provider-based stigma of OUD is a significant barrier to fighting this epidemic, and it's presented a barrier to implementing these evidence-based responses. And some of our prior work and the prior work of other researchers in this field supports this belief. For instance, some of our early work has found that public and provider-based stigma of OUD negatively predicts attitudes toward harm reduction, including naloxone and MOUD. We've also found that one's training experiences, whether or not they've taken an addiction class or a substance use dependency class, and how comprehensive that is, as well as their beliefs about addiction, whether or not they support a moral or medical model, the medical model believing that addiction or dependency is a medical condition in need of a medical response. The moral model needing that addiction or associating addiction with some form of moral failure. These beliefs are related to both OUD stigma and individual attitudes toward harm reduction. And then prior work has also found that stigma is a significant barrier to treatment availability, initiation, and utilization. So building on this work, our current project was really guided by 2 research questions. First, we wanted to know in the community, is there a relationship between stigma of OUD and support for punitive responses to drug use, particularly opioid use? Second, we wanted to know whether or not there's a relationship between stigma of OUD and support for NIMBY syndrome, or not in my backyard, not wanting this thing in my backyard, this thing being opioid treatment centers. And to answer these questions, we analyzed survey data from a representative sample of the Pennsylvania general public. And as my colleague before me said, this data was collected through the Life Unites Us campaign in collaboration with the Pollock Center and DDAP here in Pennsylvania. So looking at our key measures, our first key dependent measure was expressing NIMBY syndrome for opioid treatment facilities. And this variable came from responses to one statement included in the survey. I would prefer that opioid treatment centers not be located near my home. And we dichotomized those responses into yes, no. If a respondent indicated yes, that would indicate support for what we call NIMBY syndrome. The second key dependent measure was support for punitive responses to opioid use. This also came from one survey question or one survey item that was dichotomized. This item was, there should be strong punishments for people who are addicted to opioids. So yes or no again there. Our key independent measure was one's addiction frameworks, whether or not they supported the medical model of addiction. And this came from one question or one statement. Opioid addiction is a medical illness like diabetes, arthritis, or heart disease. And again, that was dichotomized into yes, you either indicated agreement with that, or no, you indicated some form of disagreement with that. And if you responded yes, then you did support what we call the medical model of addiction, as opposed to something else. And then we also included an 8-item scale measure of public stigma of OUD that we developed in an earlier paper. And before I get into that, what we were really concerned with, what we thought we were going to find was a significant relationship between one's addiction frameworks, this supporting the medical model of addiction and our outcome measures. But we thought that relationship, given these previous findings in the research I just talked about, we anticipated that this relationship would be indirect, that it would flow through stigma of OUD, meaning that those who supported the medical model, they didn't support or those who didn't support the medical model of addiction, those who supported the moral model, they would hold higher levels of stigma. And this in turn would lead to support for NIMBY syndrome and then support for more punitive responses to opioid treatment. So let's look at our findings. So this first table here is looking at 3 different models. The first model, NIMBY 1, that's regressing that dependent measure we call NIMBY onto all of our predictor variables except for stigma. And that was done to establish a baseline relationship between supporting the disease model of addiction and NIMBY syndrome. And we do see that there. The second model is looking at establishing a relationship between supporting the disease model of addiction and stigma. And we found that again. The full model is the complete model. We have every variable included in there, looking at that indirect relationship, seeing what happens when we include our measure of stigma in modeling, and then looking at the indirect effects there. And as anticipated, there is a significant indirect effect going on there. The direct relationship found in baseline models between supporting the disease model of addiction and supporting NIMBY syndrome is rendered insignificant once stigma is included in this model. And that's as we anticipated. So this is just a visual display of the mediation effects going on there. It makes things a little more easier. Essentially what we found is that baseline model that indicated supporting the disease model of addiction was directly related to supporting NIMBY syndrome. That's no longer significant once you include a measure of stigma of OUD. So what's going on there is one's addiction frameworks is directly related to their stigma that they place on opioid use disorder. And that in turn shapes whether or not they support a NIMBY syndrome for the location of opioid treatment facilities. The second group of models here is just regressing our second dependent measure supporting punitive responses to opioid use onto our relevant predictors, and we find the exact same thing. Same thing going on there. Baseline modeling, there was a significant relationship between supporting the disease model of addiction and support for punitive treatment of opioid use, but once stigma is included, that relationship is indirect. So what are the implications of these findings? Well, empirically, we've established a relationship between addiction frameworks, stigma, support for punitive treatment of OUD, and NIMBY syndrome. And as we anticipated, this relationship is indirect. There's a mediating effect going on there through stigma. Someone who supports a moral model of addiction holds higher levels of stigma of OUD. They're less supportive of having opioid treatment centers built in their communities, and they're more supportive of holding punitive responses or having punitive responses for opioid use. Practically, what this means is that stigma is likely a significant barrier still to treatment availability, access, and utilization. If individuals in the community hold these attitudes, they're not going to be receptive to having these treatment centers being built in their communities. And a lot of times that's going to prevent some centers from being built in areas where they're needed. So what this suggests is a possible need for educational programs aimed at changing addiction frameworks, and then ultimately stigma or anti-stigma reduction campaigns. And we're looking right now into expanding this into other regions, looking at it longitudinally too. So, thank you.
All right, great. Thank you, Dr. Cruz. And it's going to definitely be interesting to see what the outcomes are as you expand into other regions. We already have a couple questions coming in, so please feel free to use the Q&A feature on this webinar, and we will address those at the end. Our next presenter is Ms. Erica Saylor. Erica obtained her MPH from Penn State College of Medicine, and she's currently a research associate at the Douglas W. Pollock Center for Addiction Outreach and Addiction. So Erica, take it away.
Thanks, Weston, and good afternoon, everybody. I'm going to be switching gears a little bit with my presentation. My two colleagues that preceded me talked a lot about the research and evaluation pieces that are going on with Life Unites Us, but I'm going to be talking about some of the community pieces that we're working on with the project. So specifically leveraging feedback to inform tools and resources in the community within Life Unites Us. So I'm briefly just going to touch on Life Unites Us as it's relevant to what I'm talking about today. And I'm going to talk a little bit more in detail about the community engagement work we do and feedback mechanisms that are incorporated within that work. And then how we leverage that feedback that we collect to inform our tools, resources, and opportunities related to this campaign. So Life Unites Us, and I know Dr. Kynek had shared this in previous presentations here at Howard with the International Conference on Stigma. So again, I won't spend too much time on it, but Life Unites Us is a statewide campaign focused on reducing substance use disorder stigma across the Commonwealth of Pennsylvania. And it's done in conjunction with Penn State, as well as the Public Good Project, Shatterproof, and the Department of Drug and Alcohol programs here. And the way that Life Unites Us accomplishes this is by utilizing social media to share stories of real Pennsylvanians that are in recovery. And we also work closely with organizations across the state and share tools, resources, and data that we collect on stigma and stigma reduction work. So really kind of the end goals of all of this are to increase knowledge about substance use disorder, improve attitudes, and also increase behaviors as well, with the ultimate goal of decreasing stigma. And this is done through kind of three different arms here that I'm going to discuss. The first being kind of the native piece of pushing out these stories of hope and resiliency of people in recovery through our website and social media channels. And then we kind of have a paid strategy where we utilize digital influencers and targeted paid media to drive the message further into populations that might hold stigmatizing views. And then the third arm here, which I'm going to touch a little bit more in detail on, is our community-based organization or CBO outreach. You know, in Pennsylvania, we have a ton of community-based organizations across the Commonwealth doing a lot of really great work in the substance use disorder treatment and recovery spaces and the stigma reduction spaces. And we really want to connect with them to elevate the work that they're doing and support that work with any tools, resources, and other items that the campaign can provide. You know, we really know that stigma reduction is not the result of siloed stakeholders, but really effective when we all work collaboratively. So as a way in our work with community-based organizations, we really are intentional about how we engage with them and the information we collect with them from them, and how we utilize that to improve the experience of the campaign, improve the messaging, as well as developing tools, resources, and other opportunities. So we have a variety of different mechanisms here. The Community Impact Committee and qualitative data collection, I'm going to dive a little bit deeper into here in a moment, but we also do informal technical assistance when we connect with partners to onboard them with the campaign, people provide very candid feedback and we always incorporate that. We also survey folks if they're on any of our webinars to get any feedback there, as well as folks who are sharing their stories. We also want to keep that feedback loop open to see how their experience is. So one of the big feedback mechanisms that we utilize in this process is the Community Impact Committee. When the campaign started, we really realized that to enhance the work and drive the work deeper, we really needed an advisory committee to provide some guidance, maybe in areas that we were lacking. And one space in particular was in the recovery community. So we developed an advisory committee comprised of folks in the recovery community to provide candid feedback on messaging on the campaign offerings, the campaign structure. And we utilize discussions with these folks to make direct adjustments to the campaign. Currently, there are 5 folks from across the Commonwealth that sit on the committee. And again, we really value their feedback and utilize that as a way to improve the work that we're doing. Secondly, Dr. Kynak talked a little bit more in detail about this, but we utilize semi-structured virtual interviews as part of the qualitative data collection pieces of this campaign. And these interviews really help contextualize the stigma reduction work happening within the Commonwealth. We connect with a lot of different groups with these interviews, and we really want to understand how these organizations, stakeholders, community leaders, individuals are addressing this stigma and ways that we can support that. And we also connect with them to better understand, if they've engaged with the campaign or ways that the campaign can be improved. And we utilize this as well to inform the work that we're doing and the offerings that we're putting out there. So as I mentioned, all of this feedback we're gathering, all these different mechanisms are really utilized to support the work that community-based organizations are doing. And I'm just going to share a few of the tools, resources, and opportunities that we've kind of worked on so far. So I already talked about the Community Impact Committee, but I included it here as well because this is actually an opportunity for community members to get engaged with the campaign. We regularly recruit for the committee itself. It is a paid opportunity to engage with us. And the committee members really get to work closely with us on a variety of different initiatives that we're working on. One of the really recent ones that was interesting was revamping our story library and kind of organization to kind of make that a little bit more streamlined for folks to work on, as well as our data dashboard and ways that we're displaying data to make it more easily accessible for people to utilize. Another one that we're really excited about that we've come up with recently, we've gotten a lot of feedback from folks that they really want to engage in stigma reduction work, enhance the work they're doing, but they just don't have the capacity to do it and could use funding to be able to expand that work. So we started offering a community award grant program where we award different organizations across the Commonwealth to enhance the work that they're doing. This year, we've awarded 5 different organizations doing a variety of different things across the Commonwealth, like different speaker series focused on recovery, as well as Pittsburgh Recovery Walk and some other organizations doing work in the friends and family space, as well as others. We also offer trainings and webinars. The first year of the campaign, we were doing them monthly, but have switched to a bi-monthly cadence. And these really are driven by the feedback we receive. So we directly, present on topics and get speakers relevant to things that we've heard feedback on. Some common ones that we've done recently: recovery-friendly workplaces, pregnancy stigma and opioid use disorder, police as partners in addressing substance use disorder. And a more recent one that we just did that we actually had been hearing a lot of feedback for quite a while was on social media engagement, how to create your own content and utilize that as well. So we continue to utilize that feedback to offer trainings and webinars for folks. We also started sending out a newsletter, monthly newsletter, and the newsletter is a really great tool and opportunity because it directly kind of puts some of the digital assets and content on maybe what to share that month kind of at the top there. So folks that are partners with the campaign or receiving the newsletter can just easily highlight specific stories that have already been kind of that are going to be showcased this month. and just easy, plug into social media, which can be really helpful for folks looking for social content. We also promote and provide information on upcoming webinars. We also have monthly data briefs. And we also love to showcase partner events and activities going across the Commonwealth as well in our newsletter, so they can connect with other people and see what others are doing as well. And lastly here, we're really excited about this one. It just rolled out. We developed, in response to some feedback, a community building workbook. A lot of the folks at organizations that we work with wanted more tools in their toolbox, especially in the space of engaging and collaborating with others doing this work, and better understanding their communities. So we developed a workbook that contains tools for community-based organizations to better understand their communities, to strengthen the connections with folks that they have, and also to utilize social media to enhance their efforts. And we continue, like I mentioned, to utilize this feedback. In the future, we would really like to provide more resources for friends and family members. Also, emerging trends in substances. I know fentanyl has been a big one that we're planning to do some push on with messaging and resources, as well as expansion of diversity, equity, and inclusion efforts for the project. And that's all I have today. If anybody has any questions, feel free to put them in the chat, or feel free to email me directly, and I would be more than happy to answer them. Thank you.
Great, thanks, Erica. The Life Nexus campaign is definitely very comprehensive, and especially when we're working with community partners, it's always important to remember that we need to give them the support so that they can be most effective. Our next presenter is Ms. Erin Bergner. Erin's a research assistant at the Criminal Justice Research Center at Penn State Abington, and she's going to be discussing the perceived impact of storytelling on substance use self-stigma. So go ahead, Erin.
Thank you, Weston. Go ahead and share my screen. Perfect. So hi, everyone. Like Weston said, my name is Erin Bergner. I'm a research assistant at the Criminal Justice Research Center. This was actually some research that was conducted by one of the faculty at Penn State Abington, Dr. Glenn Sterner. Unfortunately, he couldn't be with us today, so I'm here to present on his behalf. I will be talking a little bit about the perceived impact of storytelling on substance use self-stigma, which is essentially just utilizing narrative intervention to decrease self-stigma associated with substance use specifically. So first, I thought it would be a good idea to kind of conceptualize stigma or start a discussion about how we think about stigma. So stigma is a societal process that occurs when labeling, stereotyping, separation, status loss, and discrimination within a context wherein power is exercised. When we're talking about stigma, we consider three types of stigma: social, structural, and self. So social being stigmatized attitudes and beliefs that a society holds towards a specific population, which in this case was associated with substance use disorder. And then structural or systemic is kind of like the policy, laws, or institutional practices that are enacted in regards to negative social contexts that negatively affect these stigmatized groups. And then our study specifically focused on self-stigma, which is the internalization essentially of social and structural stigma, but it can be better defined as negative feelings about oneself, maladaptive behavior, identity transformation, or a stereotype endorsement resulting from experiences, perceptions, or anticipation of negative social reactions on the basis of stigma. So getting into utilizing narrative as a method for disrupting stigma, the use of narrative has shown to decrease self-stigma for several conditions associated with mental health, medical conditions, substance use disorder, as well as those who are justice involved. Narrative enhancement cognitive therapy was something that was introduced as a form to help disrupt stigma. And in one specific study, participants displayed reductions in self-stigma as well as improvements in self-esteem, hope, and subjective quality of life. And this specific study and intervention was utilized within the mental health population as well as substance use disorder population. Interventions using narrative noted outcomes including reductions in stress and secrecy, as well as stigma coping and personal growth and recovery. So the specific focus of this study is that we want to gain a better understanding of the self-identified impacts of sharing one's story of experience with substance use. So mostly just why people were sharing their stories to begin with and what purpose it served for them, as well as understanding the motivations for sharing one's story of experience with substance use. And then most importantly, exploring any negative experiences with sharing one's story of experience with substance use to help impact policy or any future narrative interventions or interventions associated with decreasing stigma associated with substance use disorder. For sake of time, I'm not going to delve too deep into the methods, but in terms of sampling, we did a purposive sample of 88 people who have shared their experience publicly regarding substance use disorder. This sample was taken from the Story Powered Initiative, which is a platform that features stories of people across the United States who have experienced stigma or been discriminated against for a variety of issues, such as their sexual orientation, any mental health related concerns, substance use disorder, justice involvement, as well as racial identity. We conducted 22 key informant interviews, and then to analyze the data, we utilized a theming analysis with a modified grounded theory approach. Some sample characteristics of our participants included 68% female, 32% male, as well as majority of our participants being Caucasian, with 9% of our participants being Black or African American and 5% being Latino or Hispanic. Our ages ranged from 22 to 71, with 36 of our participants being in their 50s or older. 77% of our participants supported a loved one with substance use disorder, and then 45% identified as a person actually in recovery from substance use disorder. We split the categories of the responses that we received into 3 different subjects, one being personal impacts, hopes and motivations, and then negative experiences. And now I'm going to kind of walk you through some examples of some qualitative examples that people shared that we pulled through their interviews regarding to these specific subcategories. So starting with personal impacts first, the agency to positively impact others. I'm going to go ahead and read the quotes associated with each just so you guys can get a better understanding about where people are coming from. So this individual stated, so I started working at a halfway house and it was like my life came full circle or something. All the help and all the things that all of the techs there and the counselors and everybody had given me. Maybe now I can give some of that back to all these new clients coming in and all these people who were just starting recovery. So a very good example of someone with lived experience, a person in recovery, now taking their experience and paying it forward by helping individuals within similar circumstances. Following along the same theme with purpose, another example was the good to that is that the negative experiences made me hungry. It's given me a purpose in life because I have a gift to communicate. It's made me never want to quit. I feel like when I get up every day, you couldn't pay me enough. There's nothing else I'd rather be doing but to be speaking and uplifting people. And I think that this is a very powerful example of turning what this individual identified as a negative experience into something positive, which really speaks strengths to this individual's resiliency. So increased and strengthened connection to others, as we know that something with substance use disorder, isolation and lack of connection is something that these individuals struggle with, even though supporting loved ones with substance use disorder, as my previous colleagues had discussed, at the family level. So this individual stated, and one time I spoke and my brother and niece showed up. My niece was 16 at the time, and they never said they watched my video. We never really talked about it. They know all the details because my brother is my brother. I tell him things. And he came and he listened to me speak and he saw everything that was going on. And he came up to me and he's like, I just never really knew any of that. So a clear example of how much stigma can prevent itself or present itself within the family systemic identity, in the sense of that, like, here is someone with a very close loved one who knew very little about their substance use, whether that's due to the internalization of self-stigma as well as social stigma. Perhaps one of the most important themes that was noted that we found was that the improved view of self. So this individual talked a little bit about how sharing their story began to increase their self-confidence. stating, so slowly, when I would start sharing my story and just start talking in meetings or just one-on-one with people or things like that, I slowly started to get more self-confidence. I started to believe more in my ability to make better decisions, to try to really be a better person, and not just because I wanted you to think that, but because I started not to hate myself more. So kind of decreasing that pressure of needing to be something that you aren't, but genuinely being it because you want to be. And then of course, relief, being able to share your experience, it can kind of get that weight off your shoulder or that burden that you're carrying of that secret within yourself. So this individual stated, and the more I was able to talk about it, the less weight it had, the less power it had. And then seeing how it helps other people almost give themselves permission to talk about things that they were never going to mention as well. And you see them get relieved of the weight and the communal aspect of it. Moving forward from trauma, as we know, people who experience substance use disorder often have a trauma history, whether that's prior to engaging in substance use disorder or during their active substance use disorder or post-recovery. Trauma is something that is very common within this specific community. So this individual talked a little bit about how sharing their story allowed them to move forward from their traumatic experience, stating, sharing my story allowed me to grieve. We're just not allowed to grieve. I should have been over it. I should have gone on with it. And why do I do such sad things by speaking and sharing my story? Because it was the only place I was allowed to talk and not be interrupted. It's the only place I'm allowed to cry and not be shut down. So for me, sharing my story and speaking to people is where I could grieve. We have increased hope. Personally, I'm really glad that I was able to put this story out there, and it gave me almost a drive or reason to. It gave me hope. Even though my son's time has passed, it gave me hope to keep going on day to day and keep progressing. So that was an individual who lost their loved one. And then lastly, power reclamation, because I decided to tell my story. I decided to share my story. I literally broke a cycle of generational stigma, of generational single parent homes and drug abuse. I've stopped a lot of mess that I grew up in. Now I don't know what's going to happen in the next generation, but I know as of right now with me that I've been able to put to rest just for the day a lot of garbage. Sharing my story, I took my power back. So some implications we found from the research that we had conducted is that more research needs to be done on storytelling and self-stigma reduction specifically for substance use. There's a lot of research out there associated with mental health, but not substance use disorder specifically. And then considering possibly utilizing this as an intervention to reduce self-stigma for substance use to help those get in better insight into their own recovery process, as well as get more individuals involved in their recovery process. And then lastly, implications for the network around an individual who uses substances. So kind of decreasing that self-stigma and social stigma associated with one's social network, such as family, friends, peer support, any outside individual. And then if you have any questions, feel free to put them in the chat, or you can contact Dr. Glenn Sterner at the email below. Thank you.
All right, fantastic. Thank you, Aaron. It's great work that you're doing down at Abington. It's very important for people to be able to share their stories, not just those with substance use disorder, but also friends and family members as well. It looks like we're doing actually pretty well on time here, which is wonderful. So thank you to all the presenters. I know it's a little bit of a rush, but I want to thank you all. Our next presentation is by two very accomplished professors, Dr. Jennifer Murphy, Associate Professor and Chair of Criminal Justice at Penn State Berks, and Dr. Brenda Russell, Professor of Psychology at Penn State Berks. So they're going to talk about reducing stigma among college students and some of the great work that they're doing on their campus and their program. So go ahead, Dr. Russell.
Hi, thank you so much, Weston. I appreciate it. Can you see, is it up on the screen? Because it's not up on mine yet.
Yes, we can see it.
Okay, great, great. Well, thanks for being here, everyone. And so this is reducing stigma in college students. And we'll tell you a bit about what we've been through since 2019. So we've been pretty busy. We're talking about improving addiction knowledge with our students. We also did a session, a pre-session training for faculty and staff in December of 2019. And then we did an in-person training session for students that was a bit more involved. This also included an on-campus campaign. So we'll talk about that. And then the virtual training sessions that were going on right now and continuing on. This work was actually, we received a grant from the Department of Pennsylvania Drug and Alcohol Programs. So as you can see, there were quite a few versions of this research. For today, we're going to focus primarily on the student training and the campaign. So the educational session, so we did one with faculty, and it was kind of, it went very well and the results were good with that, but we wanted to ramp it up a bit for the educational training for the students. It was longer, it was 3 hours long. There were 4 presentations that were included in the training. One was a medical doctor specializing in addiction, so he addressed the science of addiction and contemporary treatment options. This was followed by 2 speakers who discussed their own experiences with addiction and recovery, with a discussion that followed on different efforts in the county to encourage people to enter treatment. And Nathan, Dr. Cruz mentioned this earlier about some of these programs, such as the warm handoff, things like that, and had police officers come in. The warm handoff programs were available in the local emergency rooms, and then a program where an officer and a recovery specialist would visit the person who overdosed at their homes. So these programs were designed to provide information to the individual and their families about different treatment options. And the final presentation was a training on naloxone administration. So in this situation, when the students came into the training at the beginning, they were provided with a pretest. And what we're particularly interested in was looking at levels of stigma. Was it looking at the medical model versus the moral model, now general knowledge in addiction, and then their comfort with naloxone and knowledge about naloxone as well. So we also looked at specific majors, criminal justice majors, rehabilitation majors, and psychology majors, because we assume that these are the students who within their careers and their future careers are going to be dealing with this more often. Once the session was completed, they did post-tests. And we also examined a control group of students who did not attend the education for the same majors. And the results, we then compared the post-test or the control group with the experimental group or the training group. And just for your information, I thought this was very interesting. 51.5% of the students participating in the training or the experimental group knew someone who had overdosed, and 36.5% of control students knew someone who had overdosed. And we're going to be talking about the campaign that we did, and in that one, 44% knew someone who had overdosed. So that I just found those astounding. So take it as you will, but to me, it's just kind of crazy. So if we look at some of the results here for addiction knowledge, excuse me, student knowledge about addiction, levels of stigma, like I mentioned before. I know what an opioid is. So there were a few knowledge questions, and we found pretty much for every variable, there were increases from pre to post test, significant increases, or decreases depending on stigma. So if it's stigma, those measures decrease. So I consider myself knowledgeable. They were more knowledgeable after, or believe they were. And we also found increases in beliefs about the medical model afterwards, after the session was over compared to the pretest. And also if they started off with their moral beliefs, such as lacking good morals, or they lack willpower, something like that, those were actually reduced at post-test. Levels of blame, if they believed in the medical model, the levels of blame tended to go lower as well. And also treatment options. So at first, the scores were pretty low on, you know, should they be allowed to have naloxone, or should other medications be used, like Nathan was talking about earlier. And those were much better. They were more willing to believe in various treatment options afterwards. Where we also saw a big change from pre-test to post-test was in the training for the naloxone. At first, pretty much no one really felt comfortable administering naloxone at pre-test, and the belief that we should increase utilization of naloxone, that belief that it enables users to continue their drug use actually was reduced. Their comfort and willingness to do it was actually increased, which is great. And after the session, this is important because after the session, the training session, they all got to take home the a naloxone kit for themselves. So I think that knowledge would be very useful in their careers later on. Few things about the on-campus campaign that kind of got, this is where right after we did the training, it was COVID. COVID came up, the campuses closed down, and that was one of the reasons we were going to do a pre-post with the control group as well, to compare it to the training. We weren't able to do that, so we just used that one control group to compare. The campaign also was kind of hindered to some extent. What we did, our research student assistants actually created the flyers. There were lawn signs and sandwich boards all over campus. And we also put a television screen, the closed caption television screens from Share Your Opioid Story, kind of what Aaron was just talking about earlier. And that was running throughout the weeks as well. And it was a period of 5 weeks. And also our Penn State website, the Berks website, posted some of the flyers during the campaign. These are a few of the flyers that were used. Just so you have an example of what they saw or what the students saw. So what we did is we asked professors on campus to assist with having their students complete pre and post-test surveys during the first 3 weeks of the semester. So the materials were on campus for 5 weeks until the end of October. And then the post-tests were completed in November of 2020. And the analyses suggested that the media campaign reduced stigma and increased knowledge and openness to treatment. So there were, we had 441 responses, and it really showed promising effects despite the lack of students being on campus. And we compared students who were physically on campus to those students working remotely and those living on campus. And the results showed that students that were physically on campus had reduced stigmatized attitudes such as lacking good morals, more knowledge in opioids, knowing what opioid pain medications were and that they were addictive, but also where to go for help if somebody overdosed. And medications like methadone should be available for those with an opioid disorder. Those were on campus and were much better and higher compared to students who were not physically on campus. So thank you.
All right, great. Thank you, Dr. Russell. Great work that you're doing down at Berks research-wise, and also, training the students, naloxone, stigma reduction, especially because these are going to be the professionals of tomorrow. So really incorporating that stigma reduction message early is very important. So I would invite the people in the audience, if you have any questions, please use the Q&A feature. We do have 1 or 2 questions right now. So the first one, I believe, is addressed to Dr. Kynak. And the question is, can you elaborate more on the slide where you have community and healthcare stigma? So I think this is kind of talking a little bit about vicarious stigma and some of the stigma that we see in healthcare settings.
Yes, that's a great question. So I included that one quote on there that was specific to a doctor. That was an incident where a family was in the emergency room with their child. But there were a number of other quotes that, that had to do with people in treatment settings. So for example, first responders, pharmacy staff. So I would say quite a number of our respondents reported experiencing this type of stigma when they were trying to get their child help or their loved one help in some way. And that type of stigma is particularly jarring, because in a lot of these instances, their loved one is experiencing some type of medical emergency. And the stigmatizing behaviors that happen can really have a negative impact on the family's willingness to then continue to seek help when other issues happen again.
All right, great, thank you. The other question that we have in the chat right now is asking if we can share one of the web URLs for the study that Aaron had discussed. So Charlene, if you want to drop your email into the chat or message Aaron directly, I'm sure she can share that URL with you as well. Are there any other questions right now? I don't see anything else in the Q&A box. Another question just came in, and this is addressed to you, Dr. Russell. Dr. Russell, was there a difference in pre-post stigma rates in the intervention group between people who knew someone who'd overdosed and those who did not?
That is a great, that's a great question. And we analyzed the data a while ago, so I'm trying to remember if we did that. Jennifer, do you remember? Because if we didn't, we need to look at that. It would make a lot of sense.
I think we do have to go back and look at that. We looked at controlling for just general opioid knowledge, but I don't think we actually looked at whether or not someone knew someone who overdosed.
We may have. I'll have to go back and look at it. Yeah, we controlled for age. We controlled for a lot of different things that we didn't mention here, but that's something that I can look into. And if you want to email us, actually, I'll put it in the chat and you can email me and I'll take a look at it for you. It might be in the report. So.
All right, great. And if there's any more questions, please feel free to drop them in the Q&A box. We have a couple more minutes here. I don't know, Dr. Murphy, did you want to add anything to Dr. Russell's comments about the presentation, about the work and the campaign you're doing there?
Just that the project is ongoing, like Dr. Russell was talking about. We moved everything to an online version of the training to try to reach more students. And we're working with Penn State Extension right now to try to actually get it out into the broader community across the Commonwealth. So the project continues. We had promising results based on our relatively small sample that we started with. So we're hoping to keep going and gather more data and try to demonstrate that these trainings can be effective in reducing stigma and that they should be more widespread.
And if I can piggyback on that too, one of the things we tried to do, again, this was COVID time, and a lot of our students who went through the training were kind of upper level students. So a lot of them graduated. The hope was to also measure longer term effects. So to go back a couple months later and measure them again. And unfortunately, we only got about less than half of students who responded, but that's something that I think is extremely important. You know, is this a long-term effect or is this just a, you know, short-term effect? And more research really needs to do that.
Great, thank you. I'm not seeing any other questions in the Q&A. Charlene, I do have your email that you put in there, and I'll make sure that Erin gets that so she can send you that link. Another question just came in for Dr. Cruz. So somebody on the desktop app asked if you're working with any harm reduction organizations. And Dr. Cruz.
I was trying to unmute myself there.
Okay, that's what I thought.
Find it there. Yeah, that's a good question. So I actually have a harm reduction background. I used to work at an MOUD facility, a buprenorphine facility. That's where my motivation for this project comes from. Right now, I'm working with a group based out of Baltimore with some treatment providers down there. They just passed some legislation in Maryland where the detention centers down there have to offer all 3 forms of MOUD. So we've been doing some research down there in the prisons with treatment counselors down there, assessing levels of stigma and looking at some of these issues right there to see, you know, what types of interventions we may need to launch to really get access to this treatment in a criminal justice population. So good question.
Great, thank you. And another question here. Do you think the rate of students who knew someone that had overdosed was higher because of the chosen fields of study in the training? So Dr. Russell, Dr. Murphy, I think it's kind of directed towards you in the trainings that you had discussed.
Yeah, excuse me. Yeah, I think it's definitely a possibility that that was the situation. I'm actually, Jen, did you have any?
Right, and also the county where our institution is located, I wouldn't say it was one of the highest as far as overdose death rates in Pennsylvania, but it was definitely in the higher half of counties. So, you know, it would not be unheard of for people to know someone who had overdosed based on the number of overdoses happening there.
Great, thank you. We have time for maybe one more question if somebody wants to put one in the Q&A. And then another question for Dr. Cruz. You're pretty popular, Nathan. So do you have any information on interventions to address stigma among criminal justice professionals? This person saw a presentation earlier this week about how stigma from law enforcement during responses to overdoses really harmed the family members.
Yeah, so that's another great question. And this is something that we're trying to research right now, actually building on some of the work that Brenda and Jen are doing with students and seeing what is effective for this population, because this is a population that's it's not like other populations. They're difficult to study and it's difficult to enact effective interventions with this group. So I'm working with those folks in Baltimore right now on a similar program for criminal justice professionals to see what works. To be frank with you, it's preliminary and we're not sure what types of interventions are working right now. So I don't know of any quote unquote empirically driven effective interventions right now, but it's something we're studying and something we're trying to develop ourselves.
Great, always opportunities for new research. All right, I don't see any other questions. However, if there are follow-up questions, I know that this webinar is being recorded and the presenters' emails are at the end of each of their slide decks. So I would encourage you all to reach out to them if you have additional questions. I want to thank the audience for taking the time to listen to the great research that's going on here at Penn State. And also a thank you to all of our panelists and presenters today. for the fantastic work that you're doing across the Commonwealth and also for sharing it with this international audience. So thank you all very much, and I hope everyone has a great rest of the day.
Thank you. Thank you, Weston.
Thank you, Weston.
Thank you,
Thank you.
Weston.
Thanks, everyone.